Good evening and welcome to the second webinar by the Breast Health Foundation. Welcome to everyone and a special welcome to our guest speakers tonight, Professor Carol-Ann Benn, Dr Devan Moodley and Dr Liza Jordan. Our topics tonight focus on celebrating youth. Answer your questions on young women and the aesthetics of breast cancer.
Hello. Good evening, hello.
We are just going to wait another minute or two to make sure everyone is ready and then we will begin.
Hey Lisa, glad you're on. I'm
Hi,
doing
Prof. Thank you.
from my phone. Hi Dev, thanks for on. Hi Caleb, thank you, and thanks Louise. So looking forward, everybody.
Hi, good evening, everyone. It's so nice to go through the list on the side, and I see some names here I haven't seen in ages or spoken to in ages. So welcome. Nice to have you back online with us. And I see they're from all over the country as well. So I think Carol and team, we're doing the right thing here because we're dragging everybody out from their warm, snuggly couches to come and join us on a Wednesday night. So hi, everyone. Nice to see you joining us.
Everyone said it, but I'll say it again. Good evening and welcome to the second webinar by the Breast Health Foundation. Welcome to everyone and a special welcome to our guest speakers tonight, Professor Carol-Ann Benn, Dr Devan Moodley and Dr Liza Jordan. Our topics tonight focus on celebrating youth and answering all the questions on young women and the aesthetics of breast cancer. So without further ado, let's welcome, and we'll go top down, Professor Benn, the head and founder of the Breast Care Center of Excellence. Welcome, Prof.
Thanks.
And in absentia, Dr. Moodley, the head of the Multidisciplinary Committee for the Breast Care Center of Excellence. And Dr. Jordan, specialist of plastic and reconstructive surgery at the BCCE. Now, if everyone's ready, we can start off with a question that spurred off this session.
Hello, everybody. And I'm sure Dr. Jordan can share her screen and Deb should be online soon.
Joining us right now is Dr. Moodley. Welcome, Dr. Moodley.
Hey, Dave. How's it? Righto. Today we're talking about youth, something you and I have forgotten.
Dr. Moodley, you're currently muted, so we can't hear your response.
It's probably not polite.
Said, what's that?
Yeah, really. Okay. Yeah.
Right, if our guest speakers are ready, I can ask the first and probably most important question. Right. So the question that spurred this all off was, what age can you get breast cancer? How young have you seen it in patients? And is it possible for women to get breast cancer in her 20s?
Okay, so I've had a 18-year-old, 17-year-old. In fact, Devin and myself treated a matric 17-year-old with breast cancer many, many years ago. Definitely had 18, 19, 21-year-olds. I've had a 10-year-old with a secretory carcinoma of the breast, which doesn't spread and is rare as anything. You can get it in your 20s. Anyone can get it. But that's why we have wonderful people like Devin and Lisa around who understand that the holistic concept of treating breast cancer. Devin, do you want to comment? And Lisa?
I think that your remarks are perfectly in line, Carol. There's no statute of limitations in terms of age. We get them across the board, you know, from very young to very old. I think there's just a couple of things about very young and very old that are relevant, but apart from that, it's in all of them.
Yeah. Lisa?
Yeah, just reiterating what you've mentioned already, Prof, and also Dr. Moodley. Absolutely, we've seen it in the extremes. And there is, unfortunately, no age that's out of bounds when it comes to breast cancer surgery. But fortunately, we have strategies and approaches to help anyone at any age. So screening is important.
Oh, thank you. I love that you say that. So it's the concept of no matter what age, check your breasts. And I think why I'm really pleased that you're on this meeting is because, you know, when you're really young, you're not quite sure. Your breasts look a little different. You're nervous about what to do and who to talk to, and you must check. Most young cancers present with a mass. It doesn't mean they have to. And I think what you need to be aware is going for something as simple as an ultrasound. And today we even have AI-based ultrasounds, means you can check it out. And don't be scared. Don't rush into surgeons to cut things out, okay? Rather have a stepwise approach to know what something is. Not everything needs an operation.
Right. Thank you for that, Doctor. And you did sort of allude straight into my next question. I'm starting to think you're reading my notes. But the next question on that is, what is usually the first sign of breast cancer in young women? And you mentioned, of course, the various different screening methods, but are there other ways for a young woman to tell if she does have breast cancer?
Yeah, so I think you need to know your body. You need to check your body. Don't be scared to take your top off in front of a mirror and check. All breasts are asymmetrical, and Lisa will talk about the fact that you can have different sizes, different shapes, extra breast tissue. But if it's not the norm, not something you see every month, be it a change on the nipple, or be it a lump, or be it a gland, always have to be a breast cancer. We can see lymphomas in young people. Then you need to have a stepwise approach about seeking help, and usually a simple ultrasound, and if necessary, a needle biopsy. I mean, I sent a really old guy to Devon, had a big mass in his neck that someone wanted to cut out, and organized a sonar needle biopsy and found a lymphoma. So we can do MRIs, better ways at screening, but look at your costs, have a approach in terms of who you're going to see, where you're going to go and seek help. Go with someone older or someone you feel comfortable with, and make sure you're not rushed into things. Lisa, do you want to tell people about they can all be different shapes and sizes?
Yes, absolutely. So we always say that the breasts are sisters. Sometimes they're half sisters, and sometimes they're cousins, but they're never twins. So naturally, all women, or actually all of us, our organs and sizes from right to left tend to differ slightly. So asymmetry does exist, but asymmetry, that's the difference in sizes, shouldn't be pronounced. It shouldn't be also one breast growing rapidly faster than the other. All these are just little tips that should warrant somebody just going to see somebody like Professor Benn to just say, can you just have a look? What are your opinions? Should I be concerned? And if there is nothing to be concerned about, this is after the various investigations. There are definitely cosmetic options that you can pursue to correct that purely from a cosmetic point of view.
Yeah, and I think, you know, I think a friendly female like you with breast interests and plastics is really important. You want to be comfortable, and like you said, I love that. I'm going to use that. I love it. Sisters, but not twins. Okay,
Yeah.
so different. I think that's important. Okay, so I think with social media and look, Caleb can get me on the right thing, whether it's TikTok or Instagram or everything. Everyone looks at what's in Hollywood and all the perfection, which is often, I think, must be airbrushed to hell. Okay, then they see things and they're worried that theirs looks a little different, and you have embarrassments at school and with youngsters. So I think you must realize it's mostly not a cancer. And Dr. Moodley has a special interest in youngsters with breast cancer, and particularly youngsters who are pregnant with breast cancer. In fact, he is probably one of the biggest units around that in the country. But realize, okay, that if you are concerned, because I mean, Liza, you and I have seen these youngsters with these giant fibroadenomas that are so big they're almost coming through the skin, which are rare, but they've been sitting there because someone's too scared to seek help.
Yep, correct.
And to actually jump in on that, on the topic of young women seeking help, do you have any advice for young women looking for support services when they do have breast cancer? What exists for anyone in those circumstances?
Dave, do you want to comment on different, because it's big things, particularly if you've got a cancer as a youngster?
Yeah, look, I mean, the couple of things to know. Firstly, I mean, if you're looking for support, the Breast Health Foundation is a cornerstone of support, which you can always get to. Okay, so don't forget that. There are various institutions like the Cancer Association, which also does provide a little bit of support for these patients. Okay, these groups spring up around oncology all the time, and the biggest problem with these groups is knowing where you'll fit in. Okay,
Yeah.
sometimes there are different groups, and it's important to find your fit, because different people kind of gel with different other people, and sometimes you may find that a particular group doesn't work for you because all they have in that group is older people with metastatic disease, and you might find yourself a little bit out of sort, not in a good fit. So that's important with the support groups. Support groups are usually very good, but sometimes they can make you more anxious. Sometimes when one person has a tumor recurrence, then everybody goes to the oncologist the next week, and all the labs and all the radiology services have increased. Sorry, the phone just fell. Have an increased workload. Okay, so all those things need to be taken into consideration. Okay, so it's very important, therefore, to have a situation where you find a decent group that has a whole lot of people, and also people with trained counselors to help you through this process. Okay, it's okay to speak to people in a similar situation to you, but every now and then, just having that without the necessary training can get you into trouble.
Louise, yeah.
Thanks, Devon. I think you've got that pretty much nailed it on the head. I think what's really important nowadays is pre-COVID, we had a lot of in-person meetings, everybody getting to meet each other. And since COVID, that dynamic has changed. And with the support services Breast Health Foundation now provides, we have various WhatsApp groups where the patients are on the groups, and they similar age, similar type disease, where they can communicate with people in a similar setting as theirs, and it's anonymous. And we find that really works well at the moment. After a couple of months, they do eventually meet each other in chemo rooms and radiation, etc. But we're finding that it's tapping into that market where people don't want to be seen in groups and don't want to socialize at meetings. And these webinars are an extension of that, where we can have talks and meetings like this, where they can still be anonymous, they can sit in the corner, they can ask their questions and get the information they need without having to be seen out there in a group or at an event or a support meeting. Thank you.
Yeah, and I think also, Louise, what it means is you can listen to something like this and then find your right fit afterwards. Because Devon, like I said, 100%. You've got to find the right thing for the right person. So you can't be a 23-year-old with a breast cancer and join the knitting group of the 70-plus-year-olds, because you're not going to have anything in common. And that's why it's wonderful for me having youngsters like Liza on, who's got an interest, because sometimes who you relate to is different. If you've got dealing with kids and dealing with cancer, and mom's losing her hair, and this is a completely different ball game to if you are 50 or 60 or 75. And then we're not saying like we can consider, David and myself consider ourselves young older people, but it's not what we relate to might be different to the person who hasn't found a partner, who's going to talk to Liza about her scars and her cancer operation and the importance of her breast and her breast milk, who may not have had kids, who wants to maybe consider a family, hasn't found a partner yet. Those are all important issues. Right.
If I might just add, when I got diagnosed 20 years ago, all the ladies in the chemo unit were pensioners, and I was 34.
Yeah.
And I couldn't relate to them.
So Louise,
talking
you
about
are just
kids,
a young pensioner.
How old are you now?
Oh God, 55.
So that is an inspiration for everyone to know about. That's why I mention it. Okay.
But I mean, things have changed so much in 20 years that the
about to
support
say,
that's
that was
available now,
Yeah.
it's very different to
And
what was available 20
and
years
remember,
ago.
the treatment you had there was Jurassic Park compared to what they can do now.
True,
That's also
true.
important.
But I'm still here. But it
I
did
know
work.
you
I'm
are.
still here.
Dinosaur that you are. You're here.
Thank you for that. Let's focus on the start of the journey. So for these next two questions, I'm just going to group them together. What breast cancer screening test do you recommend for someone who falls into the category of a young patient for breast cancer? Would they benefit from a mammogram or a clinical breast exam? And added on to that, what are the risks and benefits of breast cancer screening or mammography?
Okay, so you can do a mammogram at any age. It's when the tissue's dense, it's harder to see. So mammograms like driving in the game park looking from the side. The more dense the tissue in young people, it's a jungle. It's harder to see. So that's why we usually start with an ultrasound. But if we make a diagnosis of a cancer, okay, we'll do a mammogram and we'll do an MRI. So there's certain caveats that I'm very fussy that people don't miss. Youngsters who have a clear, spontaneous nipple discharge, and they go for an ultrasound and they don't pick up anything on the sonar. You need to, sometimes they're little papillomas, tiny little papillary lesions, but in those scenarios, before you go for things such as surgery or anything, they must do a mammogram, because if you see little calcifications, they can biopsy it, because calcifications are skeletons of cells, and often that's a feature of DCIS. And if there are things that I see missed in youngsters, it's when someone says something is a fibroadenoma and it's not, it's a triple negative breast cancer. So if you've got a little lump that looks like a benign fibroadenoma, insist on a 3-month follow-up sonar. So what is missed in youngsters are important for me. A spontaneous discharge, missing a duct carcinoma in situ, a sleeping cancer, missed in youngsters. Paget's, a change on the nipple. On average, 18 months delay. Breast cancers in pregnancy missed because they say that's what your breasts feel like in pregnancy. Do an ultrasound and a needle biopsy. Lymphomas missed in youngsters, big glands in the axilla. Dave, do you want to add anything, and Liza, to that?
Lisa?
Yeah, I would also just add in youngsters with very large breasts, I think. There's also an element of being embarrassed. I sometimes feel that I picked it up going to be examined by somebody else. I think when you're at that age, you're really so self-conscious. And to then go to someone and say, please help me examine my breast or teach me how to examine my breast might be quite overwhelming, but it is very important. And there are, as Dr. Moodley said, there's different fits. You can go to the organization, the clinic, the practice that is the right one for you at that age.
Unfortunately, you will find that when a young person goes to have a checkup, there are many centers that may say, no, you're too young
Yeah.
to do this, or you're too young to do that. You're never too young. They just need to understand that at that age, they're not necessarily going to be easily diagnosed because of the denseness of the tissues. Number two, they're not easily going to be diagnosed because those tissues are busy and they have lots of things going on. They're still being formed, they're still developing, they still have bits that are harder and bits that are softer. So therefore, it's not all simple. So the easiest way is to say, no, you don't worry, don't do it now, come back later when you're much, much older. But that's not necessarily what you want. So persist until you get someone that will help you, even if it means doing an ultrasound only to look. But there is no contraindication to do any of those tests at a young age.
Perfect. And on that subject of mild uncertainty, is there a way for someone to determine if they are at a high risk of breast cancer? And are they needing any special screening or tests to determine this? Or is it purely luck of the draw?
So 65% of people who get cancers have no risk factors whatsoever. But we often see in youngsters, the only thing you can know is you must know your family history on your father and mother side. And often, families don't talk about these things. So you kind of got to like squizzle around. I mean, sometimes you don't really want to know your family. I think my kids will say, choose your friends, not your family. But you can't your family is your family. So you want to know, particularly young cancers, lots of cancers, different types of cancers scattering together, breast, gynae, skin, stomach, colon. I was just reading something on Lynch syndromes and new oncology drugs, Devan, so while we were waiting. So I think it's about understanding potential higher genetic risk. And one of the things I'm very interested in is setting up of high-risk clinics in an environment that is not traumatizing. So if you've got horrible family history and even looking at genetics, you've got your genetics since the day you were born. You can't change your genes. So knowing just gives you power to you. It's like, and you doesn't mean you're going to get something. So you can look at your mother and say, oh, I don't want to be like that. Or you've got mental illness or blood pressure or cholesterol in your family. Knowing about it makes you safer for how you can help decrease your risk. Okay, and it doesn't mean to say that everyone is all going to get then blood pressure or mental illness or cancer, because it's not a clear genetic, just because one person had it, someone else is get it. Genes are switched on and switched off. So you want to know about family history, and then you can up your screening. Dave, Liza, do you want to comment? And I mean, if people want to put other questions in the chat group, absolutely. We're happy to take questions that we can answer, right?
Yeah, I think genetic history is important. I think you need to understand that firstly, having a positive genetic history of breast cancer, that's a first-degree relative and proven on screening does put you at higher risk. And then once you've established to be at risk, then you get incorporated into a screening program. And that happens so that if something goes wrong, we find you early. Number two, having a parent, having a mum with breast cancer does put you at a little bit of a higher risk compared to your peers. And therefore, as a rule, we expect you to start screening 10 to 15 years before the cancer appeared in your mum. Okay. But we must iterate that the majority of cancers in this situation has no identifiable risk factor. So most of the people we see on a day-to-day basis, well, they just had bad luck.
Yeah, and I think the more people, so I sit on lots of committees throughout the world around genetics and high risk, and I think the more people you test if you've got a cancer, the more you can put together in the pile the understanding of combination genetics, and the more the clever computers can start looking at AI and seeing, maybe this is this combination that causes it. Because whereas only 12% is single isolated gene, about 8% BRCA1 and 2, and the other 4% things from Lynch and Livermore and CHEK2 mutations, and weird names as as we love to confuse people in medicine with these weird names. About 25% is like opening a lock. So when I travel, because I'm an anxious traveler, all the locks in our house will be, say, my birthday, 221. So whenever I get home, wherever I am in the world, and Devan knows because he's traveled with me, Liza hasn't yet had that privilege, the locks all go 221, so I can open any bag, so I'm not going, I can't get into my bag and I can't remember this combination. So there will be for that family, it will be that combination. But when the geneticists, or when we medically look at it, we're going, oh, you don't have a positive genetics. But if you have strong family history of cancers, you screen more frequently, you make sure your house security, your body is more secure so that you can pick up things earlier, so we can treat things better. So I see there's a geneticist on, and I definitely think if you guys let us know what you want, we can get the right team on, we can do things on high risk, genetics, as many as possible. Because sitting with a cup of coffee here and everyone doing their thing is a nice way for open communication. Okay, we're going to talk. Someone mentioned about a risk factor. It came on having kids later in life. When I say 65% of people who get breast cancer don't have risk factors, I mean across the board. So at medical school, we were all taught. How old were you when you started your period? When you had your menopause? Did you breastfeed your kid? The safety is you have to have your child under the age of 18, and we're not encouraging teenage pregnancies. Okay. And you can breastfeed your children and you can still get a cancer. In fact, during your pregnancy, you're actually at higher risk of getting a breast cancer. 1 in 3,000 is the risk for breast cancer in pregnancy. Then having your kids late, sure, they say higher risk. Then we used to learn, be careful if you're a nun because you're at even higher risk. And then we were told that if you have your kids when you're in your 30s or 40s. But you know what? Life is not straightforward. Some of us don't get an opportunity to have kids until we're in our 30s and our 40s, okay? So you can fix what you can fix, modifiable factors, watch what you eat and drink and exercise, and non-modifiable factors, whether you breastfed your kids, how late you had them, if you had fertility treatment, that can't be helped. And it's still technically more dangerous driving in Johannesburg, lucky to you guys, elsewhere in the country, okay? So what you do is you take each day, one day at a time, listen to your body, don't sit with guilt about what you didn't do yesterday, and go and make sure you're checking things out. I don't know if there are any comments on what I've just said.
Remember that it's important to differentiate between causality and association. So many of the things you will learn about, you learned about because epidemiologically, in other words, when they do populations and they tot up the numbers, they find that more patients are having breast cancer when they're younger, or more patients that are having breast cancer were Black, or more patients that had breast cancer didn't have children, and so on and so on and so on. That doesn't mean there's causality between those two factors. Okay, so it's very important to understand that some of these are associations, and they might even just be statistical associations. So until we can tell you for sure what's what, there is no direct link. Okay, so that's the first thing. The next thing is there are many things you can do nothing about. So it's very important under those circumstances to accept the things you cannot change and change the things you can.
100%.
Right. And just to open the floor now to 1 or 2 questions from the chat. With regards to mammograms, what is the recommended age for someone to start getting mammograms? And are there any risks of repeated mammograms, such as those done at every 6 months or in any other time interval?
Okay, so basically, what age you do your mammogram is called health economics. So, and we looked at what happened with the US task force when we hit our, I think, and Caleb, you want to study economics, I think it was our 2008 or 2013 economic drop. Everyone changed. At that stage, we were going to move mammograms to 35 in the US. Now what we've done is we then popped it up to 50 in every 2 years, whereas Sweden was 40 yearly and the UK was 3 yearly. And in South Africa, there's no screening program. Discovery has a screening, and some of the medical aids do, and it was 52 yearly. So recently there's been a release from the task force, okay, to say that it actually should be done 40 yearly. And health economics is about looking at what cancers we see in a country and setting up some sensible system about who we screen to pick up things early. Only about 25% of people on Discovery actually use their health benefits, okay? Currently, you can start your mammograms from 35. It is more dangerous flying on an airplane from a radiation exposure than going for your mammograms every year. You guys will see on the A-team chat group, Prof Joseph will send a little horrible face at me to say, going on another plane, you know, and she'll say to me, I hope you've got a lead-plated bra, okay? So the thing is, going shopping in Santon City, there's more radiation exposure in a shopping mall than there is going for a mammogram or an X-ray. There's an international group called ALARA, which checks the radiation exposure. Here's a pop quiz for everyone online. Which is the place in the world that has the highest radiation that's not a hospital? Pop quiz. It is Grand Central Station, New York, because it's marble and it's underground. Who knew? Okay, so there we go. So don't be scared to go for your mammograms. Things like thermography are adjuncts, ultrasounds in young people. So you don't go, oh, I'm going to get cancer if I have a mammogram. Okay, unfortunately, and I think, Caleb, this is something you like to quote, basically our cells are changing all the time. So the little changes are happening all the time. You have 0 to 10 genetic changes, your cell is supposed to fix itself, and that's where the BRCAs and the genetics don't work so well. Between 10 and 80, the little hyena cells are supposed to kill it, and if they don't, then things happen. So that's why you want to screen.
Right, and another question from the chat now, with regards to risk. If someone's mother was diagnosed and is now clear, would you recommend risk-reducing surgery in daughters that are done with kids and breastfeeding, but in their 30s?
Liza.
No, I would say, I think Dr. Moodley is also talking. Devan, sorry, you're still muted.
Sorry, go for it, Liza, sorry.
No, I was just going to reiterate both of your reactions, which is the short answer is no. It doesn't necessarily mean this. There are tests, firstly, through genetic counseling, as our geneticists will know online. We do a thorough history taking. And then there are tests that can suggest higher risk with your BRCA gene testing and so forth. So it is not straightforward, yes, you are at higher risk.
So you're at higher risk for being anywhere you are. If your mom has had cancer, you look at the age your mom has had cancer, you test the index case. You don't test yourself, because if your mom is a negative and you're a negative, then you go, whew, I'm not high risk, when you may well be. What you do is you be aware of your family history, and you check and you screen and you follow safety. It's the seatbelts and airbags when you drive scenario. Dave, do you want to say something?
Look, yes, now I'm unmuted. Excuse me. I think that there is absolutely no need, if your mom has had breast cancer, to go and remove all your bits, your breasts, your ovaries, your uterus, all of that. It's actually just, that's bordering on assault. Okay, assault with a scalpel. Okay, now there are very, very clear guidelines as to when those things need to be considered. And for the most part, all of those things are only looked at in the scenario of an inherited predisposition. So in other words, when you have a germline BRCA mutation, and even then they're not considered willy-nilly. They are considered very carefully after visiting a genetic counselor and being counseled properly. Because remember, having an inherited predisposition, in other words, having a BRCA abnormality, Doesn't only mean that there are problems in the breasts and the ovaries.
Yeah.
There are a whole lot of other things that there could also be problems in that you can't whip out. Okay.
Yeah.
So it's important to know the relative risks of everything. And that will never be answered here. That will only ever be answered in a one-on-one consultation with a genetic counselor. Suffice to say, you first have to have the test and you have to be counseled, and then you sit through it.
Yeah, and the thing is, what Devan says, you can't take your pancreas out, you can't take your skin out, and you can't take out all your breast tissue. And I sat with someone today, even if you take out your ovaries, your uterus, and your fallopian tubes, you have primary ovarian tissue in your peritoneal cavity, the lining of your abdominal cavity. So surgery comes with the potential. You must always look what can go wrong. So we always have a stepwise, and as I said to someone today who I saw with BRCA, is until you walk in that person's shoes, you can't judge. It's different for each person, and it's not an instant. So anyone who offers you an instant, take your breast off and you're safe, or do this and you're safe, run away. Okay.
And remember,
Thank you for that, Prof.
The concept is risk reduction, not risk elimination.
Yeah. Yeah.
Thank you for that. And now, just to stay on time, 2 rapid fire questions. Is there a link between breast cancer and adenomyotrosis and sustained birth control use? And what are the risks to take tamoxifen for longer than 10 years, and can it be taken for 20 years, for example?
Okay, so I can see you the non-medical in the family, but we'll work through you. That's great. The tamoxifen, and I think around contraceptives. So contraceptives are contraceptive. You use them for contraceptive. Whichever one you're going to use, you use. Okay. Remember, a contraceptive is different to safe sex. Don't get me started on my little talk on condoms. Whether you're on pills or whatever, anything. Contraception is a different thing completely. And if you are taking it because you need a contraception, fine. Even if you've had a breast cancer, I just had someone call in, what contraceptions can you take? Because she wants to have a child 2 years after a young breast cancer. You can actually take anyone, okay? It's not just because you're taking it, you're suddenly putting yourself at significantly higher risk of growing a cancer. So any contraceptions, your daughters, if you've got breast cancer and they need to be on a contraceptive pill, they go on the contraceptive pill for the need for that contraceptive pill. If you don't need it, you don't take it. So I'm not pro putting a 14-year-old on a contraceptive pill just to manage her skin or just to manage this. But if you have endometriosis, if you're dealing with migraines around your periods, if you are needing a contraception, don't lie to your parents, or if you can't talk to your parents, find an adult you can. Go somewhere to a clinic and find the right contraception for you, okay? So you take your contraception. Again, different to condoms. The next thing is, can you take it if you've had a breast cancer? Yes, okay. Devan's going to talk about tamoxifen in short and long-term use, and you might want to make some little comments around contraception, and I'm welcome for anyone else too. Okay, Dave.
Okay, so at this present moment in time, the standard of care for tamoxifen use is 5 years. There are situations where we will prolong it to 10 years, and that is in a scenario where there is benefit to giving tamoxifen in terms of prevention of recurrence of disease. For more than 10 years, there is no evidence that continuing the tamoxifen is of any added benefit. Remember, tamoxifen does not come without its own warts. So one of the problems is tamoxifen gives you risks of other things, including something called deep vein thrombosis. And therefore, we don't put people on tamoxifen indefinitely. And when they are on tamoxifen, you don't just keep them on tamoxifen without appraising them of the risks. Okay, so that's the bottom line about tamoxifen use.
Yeah, I want to also say that using tamoxifen at a dose to treat a cancer is completely different to using endocrine treatment today at extremely low dose to decrease risk. So we often send people to the oncologists in this, and we've got concepts today such as baby TAMs and baby AIs, and where you can use like a quarter tablet every day in postmenopausal high-risk woman once you've corrected everything with lower side effect profile. And it's, think of it, I always say it's sunblock for your breasts. It just protects the tissue, okay? But again, whether it's that or contraceptive pills, you see your doctor first, and I love the comment, absolutely, exercise. 45 minutes a day, I'm a failure, I haven't exercised for a week. I have found another trainer, guys, that apparently I can learn a Russian martial art. I'm thinking I've added that because I meant to skip today, but my day ran away with me. So I'm sitting here, no. So tomorrow morning we will try again after my 6 a.m. meeting with Prof Rapp to at least skip for 20 minutes. So if you can try, guys, please do. Okay, any other comments on hormones there, right?
Well, not to cut the discussion short, but just to stay on time, a lot of people in the chat are asking for contacts, and this links perfectly with the most important question is, if a problem is found, what do people do next? What do you advise?
I'm very fussy about what I call, and I think all three of us on here, cost effective and medicine that is inclusive for everybody. So saying, Dave, I've got a couple of packets of medicines I need to send up the road to you, okay?
Okay.
They're not expired, okay? So all of us are very, very into the concept of proper access to everybody. So through the Breast Health Foundation, you can get access to clinics if you that we run if you're not on a medical aid. We have different concepts from different units' point of view in terms of how we can people across all costs, etc. You can always start with your GP. Can I say, take the responsibility for your health yourself, okay? Question your doctors. Don't put them on pedestals. Just ask them the questions. They need to be able to tell you how much, how often, what they're doing, what their outcomes. That's why I like the fact we're all part of a internationally accredited unit, because it means that we are on the spotlight. We are checked all the time against international benchmarks to protect patients. And that's what I want. I don't want a tea party of the three of us just making a decision that's best for us. I want to be scrutinized to make sure we're doing best for patients. And that's what multidisciplinary is. So you can always start with your GP or your clinic. You can work out where you want to be referred to. You can go for as many opinions as you like. Be aware of the costs. Louise, do you want to comment on that? From the Breast Health Foundation. They can contact in directly with you guys as well. Okay. Liza, Devan.
Nothing to add there, Carol. I mean, it's basically you need to see a medical person, and you need to see a credible medical person. And if somebody wants to do something tomorrow, then just ask somebody else first.
And Devan, I mean, I recently sent you a youngster who had 2 things of chemo for an extremely lazy cancer.
Yeah.
So I want to stress to people, when you have a diagnosis or who doesn't need it and is going to get a different treatment, but I think when you have a diagnosis, I even say my first words to people when I see them, it's your body, not the doctor's. You're entitled to as many opinions. So don't sit here. If you want to, you can see as many people as you like. It must resonate. So people who say you're young, you must take both your breasts off to treat a cancer, that's wrong. The gold standard is a breast saving. You treat, once you've got a cancer, you treat that cancer. You don't take both your breasts off.
Yeah. Once you have a cancer, how you treat the cancer will govern what happens to you in the future, not what you cut out.
The behavior of the cancer.
Yeah.
But go for your opinions and don't rush into particularly your surgeries or your anything, chemos for that matter, because until you have had good multidisciplinary review and you've gone through all the due process, because not everyone, even young people today, don't need chemos necessarily, right?
Yep. The only time you need a chemo urgently is if you have an acute leukemia. Every other time you have time.
I think what's quite if I might add, I think what's quite important, going back to what Devan said earlier about fitting into a support group as a patient, your team needs to fit in with you as well. So I always tell all our patients that query, you know what, if you don't feel comfortable with the doctor and you don't feel comfortable with the team, get a second opinion, as long as you're making an informed decision.
Yeah. And breast cancer is not an emergency. It doesn't run around your body in 24 hours.
Thank you for that, doctors. Let's dive a bit deeper into breast health in general. Now, not to take you back to med school, but I've got a long list of topics here that are normally associated with these discussions. So it'll sort of be a test on whether or not you cover all the bases. Of course, you've already mentioned some of them, but it's just important to cover all the bases, such as breast cysts or nipple discharges. Dr. Jordan did mention breast asymmetry, but other things such as mastalgia, mastatists, and breast masses.
Yeah.
Carol, I think you should start by correcting all the pronunciation, and you can go from there.
I know. Well, you can see it's an economic student. That's not cute. Okay.
Yeah, I know, it's
So
fine. It's good
I
fun.
think
He's
that-
doing well. He's
I
doing
know.
I think
I think he's
yeah,
doing very well. I'm quite
absolutely.
impressed.
So I think what I think how we should start, Lisa, I'm going to ask you common aesthetic issues that young girls have, from macromastia to accessory breast and nipples to tubulars and pollens, etc. What should they do if they're worried? When should they come see someone? When should they consider surgery? And then I'll whip through cysts and nipple discharges and pain, and Devan can talk a little bit about cancers in youngsters. Okay, right. All yours.
Right, yeah. Okay, so Prof has mentioned some of the common aesthetic, that is cosmetic issues that we do find from the younger population to adolescents, or puberty, adolescents, 20s and onwards. So large breasts, and that's quite self-explanatory, which can have some functional problems as well. And also tuberous breast. And basically, these are breasts that are just different in appearance. So tuberous, basically shaped more like a tube rather than that cone round shape that one would find in normal looking breasts. So this is something that usually happens on one breast, not bilaterally. That is not both breasts, but it can happen on both breasts, very, very rarely. And any asymmetry that is different in size and shape and appearance of the breast, again, remembering that they are sisters, not twins, from one to the other, that becomes quite obvious, especially as you progress in age. And that's when you should really ask to see someone, anyone. Now, in the public health sort of arena, the clinics will refer to tertiary hospitals, and I would encourage, again, going to the Breast Health Foundation to find out who you can speak to. So what do we do? So I will say at first, we observe. We'll do all the investigations necessary. If there's anything that we are worried about from a pathology point of view, obviously we'll get on top of that and investigate that right away. But otherwise, if it comes down to cosmetics, one breast looking very different from the other, particularly in young ages, this is from 18, less than 18 or less than 20, time is I suppose, on our side, and we use time to our advantage. So there's no need to rush into anything. There's so many options for women, which go from enhancing the breast size to reducing the breast size. And all this is we're trying to match the appearance and the sizes of both breasts. So we can do that by reducing one side or enhancing the other side. Enhancing the other side may include putting in a prosthesis. It may include injecting with fat. There are many, many options that one can consider. I forgot what else you wanted me to touch on, Prof.
I think it's I think you've Covered it all. Amazing. I think for me, what I see a lot of youngsters with macromastia and big breasts, and between the age of 14 and 18, and they all want surgery. And I'm always like, just wait a bit until your breasts stop growing. And also youngsters with quite significant asymmetrical deformities, I'm also like, get the padded bra. And I think kids are so cool, you know, just if you wear a padded bra and work things out and wait till your breasts stop growing. So don't chase repeated surgery when you're very young, because you're going to need more surgery, more correctional surgery. So
Yeah, if I can just further expand on that, Prof, that especially with our large breasts who need breast reduction. I mean, in very, very severe cases, this is when it is affecting just the development of the young woman, and pain is associated, and there might be changes on the breast tissue, such as ulceration and so forth. Very rarely we may go in and perform surgery at an early age. But what Prof has just mentioned is very, very important, because as you go through puberty and adolescence, you're still being exposed to your hormones, your breasts are still growing and changing. So the earlier you do a surgery, the higher the risk is that down the line you may need another surgery once your breasts have stopped growing. So it is recommended to wait until you've completed adolescence, and then we can sit down and have a good chat and talk about the various options. It's also important to note that at this age, you probably haven't had any children, haven't had any breastfeeding. So there's so many things to consider down the line before deciding exactly what kind of cosmetic surgery you want to have.
Right. Thank you so much for that, doctors.
I'm going to quickly, wait. I'm going 2 seconds through, okay? The most common benign lumps we see in youngsters are fibroadenomas. They can be many or single. A very small percentage of them are called giant juvenile fibroadenomas that grow really big, okay? If they grow really big, you do an ultrasound to find them, sometimes a needle biopsy, and they always get taken out through cosmetic incisions. That's why the lovely Dr. Jordan will tell you many times, she and I do together, either through the base of the breast or around the nipple. Do not let any general surgeons put cuts on your breasts, okay? So that's important, okay? Not all fibroadenomas need surgery, only the ones that grow and grow rapidly. Very rarely we see phyllodes or sarcomas in youngsters. That's why you do a needle biopsy. Cysts are waterfall balloons, you leave them alone. The only nipple discharge we're concerned about is if it leaks on its own, and I mentioned that earlier. Breast pain is common. We all get it, okay? You can get mechanical pain if you've got big breasts on the side. You can get shooting pains for your nipples. Your breast can't cough. You use a topical ointment for that. Hormonal pain around the time of your periods, okay? Evening primrose, B6, sometimes other things, okay? Those are the different types of breast pain. Okay, so I've covered cyst pain, that. Caleb, do you want to ask something else? And Devan can comment around cancers, right?
Next. Well, the cancers are pretty simple to comment on. The first thing is that the young women with breast cancer really don't have an aggressive form of cancer. As they pass 25 and 35, that the aggressive breast cancers seem to show up. So the breast cancers in the very young women tend to be a little bit slower growing than their little bit of older counterparts. Okay, so cancer at a young age does not equal chemotherapy. The biology of the cancer always trumps. Okay, so it is like your shoe size. One size does not fit all.
Yeah. Thanks, Devan. So we treat cancer on biology. Any youngster with a breast cancer must see a specialist oncologist who will discuss issues around fertility and fertility treatment prior to your treatment. And there's no such thing as rushing into treatment. And whether it's oncology or surgery, again, it's individualized per person, okay? A lot of youngsters who do have chemotherapy, who can't afford fertility treatment, We can give them things to protect their ovaries and improve the function afterwards. And you can have kids after your cancer treatment. Okay, next question, Caleb.
Well, one final question just for Dr. Moodley before we focus on Dr. Jordan. Dr. Moodley, could you comment on estrogen versus Premarin usage post-menopause?
Okay, so as a rule, what we give people when they're menopausal is a lot of doctors tend to give people estrogen replacement therapy. Okay. And they give them estrogen replacement therapy for a short period of time, and that is maximum 3 to 5 years, closer to 3 than 5, because women who don't have estrogen are symptomatic. They become symptomatic from many perspectives. They may develop a little bit more forgetfulness. They may become very ratty. They may even get depressed. They may have memory problems. And if you speak to children who live with postmenopausal women, their mothers, they'll tell you that their mothers become absolute tyrants. So, some of the times these things are needed to keep their moms on even keel. I'm not saying anything, Caleb, but having said all of that, okay.
That's why his mom lives at work.
Yeah, I know. Having said all of that, when people have been diagnosed with breast cancer, we get very nervous about giving them estrogen replacement therapy. So, as a rule, we don't supplement. Okay. Now, having said all of that, one of the problems with menopause and being older and having cancer and getting treatment that blocks estrogen is that the vagina becomes very dry and thin and friable, and sexual relations become almost impossible. So every now and then we have to do some local estrogen to increase the lining so that there's enough cells to make a little bit of lubrication. So it's a give and take. Okay, so all of these things
I'm
need to
very
be
pro
done.
vaginal estrogen.
Yeah.
Okay, Caleb, lock your ears. Your parents have a great relationship. So,
Now, was
and I've
this
been in
necessary,
menopause
Carol?
for a long time. Guys, do not be scared of vaginal estrogen,
Yeah,
right?
so it's a little bit of estrogen, and not a lot gets absorbed. A very small amount gets absorbed. So this can be managed responsibly, okay? But it needs to be managed with people that know what they're doing and not just willy-nilly have large doses of oral hormonal replacement therapy being thrown at them.
Thank you for that. I've muted Prof Ben just before she can spill any more embarrassing details. We're now going to focus on Dr. Jordan and your area of specialty. So with regards to breast implants, are there mammography centers with experience doing mammograms for women with breast implants? And can a breast reduction surgery interfere with the screening, such as a mammography?
Okay, all right. So breast implants now are very, very common. And so most radiology centers will have experience in, and radiology centers, meaning also including mammographies, will have experience with how to view breasts that have implants. There's specific views called Icklin views, and they just displace the implant in such a way to make sure that they can view the entire breast tissue. So your breast continue to be able to be screened even after you've had breast implants. Just Caleb, what was the second question? Breast reduction.
Yes, with regards to breast reduction surgery, can it interfere with screenings?
No, is a short answer. Okay, so actually breast reduction in very, very, very large breasts, having a breast reduction can actually assist you in your own self-examinations at home because you have a decreased size, more of the breast, and you become more familiar with different areas of your breast. So no, breast reduction does not interfere with screening for breast cancer.
Yeah. So,
Thank you for that, Dr. Jordan.
Both are safe and both are safe, and you can do either. Just make sure you have your screening before you do. Okay.
Thank you for that. Just to stick on topic with regards to reconstruction and plastics, How would someone know if they are a candidate for breast augmentation? Does that specifically refer to breast reduction surgery, or are there other augmentations that candidates should be viable for?
Okay, so when we talk about breast augmentation, we're talking about enhancing the breast size, shape, and appearance. Basically, what we're looking for is that young, youthful breast that some had in their 20s, some never had, but everybody wants. Okay, and then breast reduction surgery is for patients who have large breasts, heavy, giving them pain, uncomfortable, difficult to find form-fitting bras, and they want to surgically reduce. So let's just or focus on breast augmentation for now. So we are looking to rejuvenate basically the appearance of the breast. And we have, who is it for? Well, basically anybody who wants it, anybody who desires it. However, we do have a certain classes of patients who unfortunately will have contraindications to getting breast surgery or breast augmentation. So who are these? We've touched on in the adolescent and a puberty group, age less than 18, sometimes 20. I would strongly advise waiting and not necessarily going and having a breast augmentation at that age. And then also very important is anyone who is struggling with body dysmorphic disorders and any other related mental health issues that haven't been properly treated as yet, because that actually can exacerbate a patient's body image issues. If you go and you put in a pair of implants, it's not going to solve the problem, it can actually make it worse. And then any collagen vascular diseases that are not well managed, and any chronic conditions really that might be a contraindication to getting general anesthetic. Those patients may need to either be optimized before surgery and just wait and for a delayed later setting when it's safe to have a general anesthetic. So to answer your question, it really a large group of the population would qualify for breast implants. However, we'd have to look at the patient's specific medical history and so forth.
Thank you for that, Dr. Jordan. And on continuing on to this discussion, are there any risks involved with breast augmentation?
So again, when we speak of breast augmentation, there are various ways to increase the size of the breast and give you more volume and shape and youthful appearance. One we've spoken about a little bit is putting in implants and prosthesis. That's the fastest way really to do it. Another way to proceed with breast augmentation is fat filling, where we do liposuction in another area of the body, and we use that fat to inject into the breast to give them a fuller, more youthful shape. And then there's also a hybrid option where we use both the prosthesis and also putting in some fat. And then lastly, you can use a flap surgery. And a flap is basically just a unit of tissue that is moved from one side of the body, one part of the body to the breast. So what are the risks? The risks are different depending which of these surgeries that you might go for. I think because prostheses are very, very popular, it's important just to highlight some of the very well-known risks. Capsular contracture is one of the biggest risks for any implant-based surgery. And a capsule is basically something that forms around a foreign body that is implanted in the body. It happens with all types of foreign body, not just within the breast. And it's basically just a mucus, sort of like membrane that becomes a scar as time goes on, and it forms around the implant within the breast. And that part is completely normal and expected. However, as a complication down the line, it can harden as the scar becomes contracted. And that's what we call capsular contracture. And it can have a very adverse cosmetic outcome on the breast. You can see it, sometimes you can feel it. And in very, very severe cases, it actually produces a lot of pain and discomfort for the patient. And that may need secondary surgery, and we're talking down the line, 10 years plus, usually somewhere around that time, to remove the capsule and also remove the implant at the time. So that's, I think.
And on that note, Dr. Jordan, with regards to additional implant-related operations, how many can one expect to get over a lifetime?
So I don't know if we have any companies that are on this evening, but there may be one or two that might say that an implant is lifelong, but that hasn't been our experience in plastic surgery as yet. There is no lifelong implant. There's always a redo revision surgery, and that time period is variable according to that capsule contracture rate. In terms of revision in the early period for a breast implant, unfortunately, it can be quite high. You can get up to 20, 30% revision, and it can be for multiple of reasons. Patient dissatisfaction, sometimes there's a little bit of asymmetry, and displacement of the implant as well. So although it is not very common, you can have revision or need to have revision of that surgery in the early period as well.
And with regards to dissatisfaction with the outcome, what are a patient's options in that case?
Well, in my experience, I'd say the first option is your best, which is to wait it out, to see what the breast is doing, because there's still healing that needs to take place. There's a lot of inflammation and swelling, and the breast appearance can change quite significantly within that early post-operative time. And therefore, how you see your breast and your happiness after the implant surgery might change. So give yourself time, let it settle. Afterwards, if you're still not happy, obviously you would consult your plastic surgeon again. And there are various options, from minimal type of interventions, maybe injecting a little bit of fat, maybe excising a little bit of tissue to correct some of the position of the nipple. And as a last option, obviously, we can remove the prosthesis and change either the size or the shape of prosthesis to give the desired cosmetic outcome.
Thank you for that, Dr. Jordan. On a different subject of conversation, how is a patient's ability to breastfeed affected by breast augmentation? And on the other side of the coin to that, how can a patient expect their implanted breast to look after pregnancy and after breastfeeding?
Gravity is not our friend.
That's right. Gravity doesn't stop after the surgery. So to answer the first question, about 20%, sometimes up to 30% of patients who receive breast augmentation are not able to breastfeed, or have problems breastfeeding, or extreme pain breastfeeding. But that number is not very clear, because there is a percentage of women who would have problem breastfeeding regardless of whether they had implants or not. Going back to what Dr. Moodley was talking about, association and causation. In that setting, there's not really a way that for us to know if you are having problems with breastfeeding because of the implant. We don't really know, but the percentage is somewhere around 20%. So after you have your implants and your breasts are looking beautiful and young and full and high up to the ceiling, not quite, but beautiful breast, and you do fall pregnant and breastfeed, unfortunately, as Prof said, gravity has its role. And there will be some laxity, that is excess skin, because your skin has now stretched with the pregnancy and perhaps the weight gain and some of the swelling. And also the position of the implant can also change as a result. So it can be affected, and it is affected by pregnancy and breastfeeding.
Thank you so much, Dr. Jordan. Now to bring Prof Ben back into it. There's a question here about precancerous breast conditions, such as atypical hyperplasia and LCIS and DCIS. What is the effect of previous... Would you care to comment, Prof? Prof, you are currently muted.
Okay, sorry. We don't usually see atypical ductal hyperplasia and LCIS in young women. It's uncommon. You can see it associated with something, but you usually see it in perimenopausal and menopausal women. You do, however, see DCIS, which is a wannabe cancer, as Dr. Moodley calls it, a cancer that is not invading. We do see that in young women. So risk lesions, how do we manage them? Today, there's a complete change in management. You do what I call a clinical radiology pathology review meeting, and in a large percentage of people, you don't need to operate. That's for the atypical ductal hyperplasia. And what you would do is you would correct correctable factors such as exercise, hormones, alcohol, etc., and sometimes use baby TAM. If you have a DCIS in a young woman, you're better off taking it out. And again, not a mastectomy. Less is more is the rule in surgery. And I loved all Liza's comments around plastics and recon because they're very sensible. So surgery can go wrong. So anything can go wrong. So just go in a stepwise approach, because it's all well when you're 20 to decide you want to do something. And then when you are 70, you're sitting with the sequelae of what you did. So just think long and hard and just love your body for your body. Okay, we're all different, thank God. Okay. So DCIS in young women is treated with small surgical procedures because we can't really give them hormone blocks in the very young woman. For the low-grade DCIS, and the high-grade DCIS definitely requires breast-saving surgery. They often all get sent to Dr. Moodley, who will often organize genetic profiling on these little cancers, and that would be my story on risk lesions. Okay, I hope you've got some nice questions for Devan. I want us to put him on the line. Cancer on pregnancy, all sorts of exciting things. Can you have chemo during pregnancy, Dr. Moodley?
Easily.
Okay,
we often give people chemo during pregnancy, and pregnancy and cancer isn't an indication for termination. So it's important to understand that if you are young and you happen to fall pregnant and you have a breast cancer and it gets diagnosed in your pregnancy, that isn't an indication for termination of the pregnancy. We can give you chemotherapy, we can deliver the baby, and then we can finish your surgery or whatever else needs to be done for the breast cancer. Okay, but I mean, I'm stealing the man who's running the show's thunder, so we'll let him do his bit.
Right, Caleb.
Thank you. And one final question for the night. What is the effect of previous radiation therapy to someone's chest? Does this impact future treatment or reconstructive treatment?
We can start with Lisa.
Oh, you're going to start with Lisa. Oh, the hard part, the reconstruction. Oh.
Yeah.
Yeah, radiation on tissue is something that's not our favorite as plastic surgeons. So you get a lot of scarring, something we call fibrosis, and that tends to improve over time, which is why when a patient has had radiation over the breast or over mastectomy scars, we were asked to wait at least 18 months before going in and doing anything surgical. That period might be a little bit shortened if the tissue is looking very healthy, soft, pliable, minimal to no skin color changes. And basically, we're just looking for skin or tissue that's going to heal after the surgical intervention. Because what you don't want is to cut into a scar somewhere that's hard and there's poor blood supply because of the radiation, and then it doesn't heal. And now you're sitting with more than one problem. So but however, you do have a ton of reconstructive options after you've had radiation. It just depends on how the tissue is looking, the health of the tissue, and of course, what your other options are other options that are available in terms of your body habitus. Are you a smoker? Do you want prosthesis or you want to use your own tissue? These are all things that will go in great detail during the consultation, just to let you know what are safe possible options for you.
I think my approach to the use of radiation in cancer management is quite a simple one. Radiation is used in two broad categories. It's used in a curative setting or in a palliative setting. In a curative setting, it's used as an adjunct to surgery to intensify local control. So whenever somebody is at breast conservation surgery of any sorts, radiation is indicated. Radiation and chemo and surgery is never an either or. They all have their place and all have their individual indications. So you never substitute one for the other. So in other words, you don't radiate somebody because you couldn't cut properly. You either radiate them because they have an indication, or you don't radiate them because there isn't an indication. One is never used as a substitute for the other. And then the last thing, in terms of when giving treatment, like chemotherapy, radiation always is delayed after chemotherapy. And the reason is very simple, as Lisa alluded to. When you radiate tissues, you make them non-vital for the most part. So what you do is you cut down the blood supply. So when you cut down the blood supply, you find that the chemotherapy can't get there as well as it could have if I didn't radiate that area and gave you chemotherapy. So that's why you will find if we're going to give you chemotherapy in the curative setting, okay, that we give you the chemo first and then the radiation comes last in that chemo, surgery, radiation, or surgery, chemo, radiation order. Okay, so that's what it's done. In the metastatic setting, radiation has a particular place. It is used in some medical oncology emergencies, like if there's an impending cord compression. So there's a large spread metastatic lesion into the spine or into the brain. We use radiation to treat that. Okay, if there's impending cord compression, we use radiation to treat that. We never use radiation just as to treat a lesion when it's not symptomatic or it's not sore. So radiation as a definitive form of therapy in breast cancer does not occupy pride of place. So it's not a definitive therapy, but a supportive therapy that's used in combination with other therapies because of the nature of the disease and because of where breast cancer goes.
Fully agree with that. And you need to know whether you need it before you start treatment. So the thing that I stress most about is when I see people who halfway through a chemo or halfway through something, and there hasn't been clear documentation at the start of the treatment. So multidisciplinary care is that when you are diagnosed, before you are diagnosed, you have a in place so that all aspects of your treatment are put together to protect you. It's your safety issues for your cancer journey. It's your visas and your passport. What should you start with? Are you going to need this when you finish? Have they put a marker in before you've started your oncology treatment? Can we find out where it is? You want to have seen your plastics and your reconstructive surgeon. you've got, not someone just says, well, cut it out and radiate, or take your breast off and put a prosthesis in, and you have risk and complications and losing it. So the rule is, start as the way you mean to go for. Set up, check your team, go through all your processes, keep copy of your notes, okay, and understand that it's a dynamic process, but you want to know everything that you are going to need to have. There's a very nice thing I think I wrote called WhatsApp Doc, how you check your doctors, okay, and just take a slow and sensible approach to everything. It's all ready from my side. Lisa and Deb, do you have any comments or questions? Devin,
Happy.
next month you and Barent are doing male breast, hey?
Okay.
Okay.
No problem.
Okay.
Thank you very much.
Okay.
Thank you very much for that, Prof. Just to close, thank you once again for an incredible informative session. Dr. Benn and Dr. Moodley, thank you for your commitment to this initiative. And Dr. Jordan, thank you for being our guest speaker tonight. Finally, a huge thank you to Louise at the BHF for spearheading this program. As always, the benefits of such events as these is further reaching than we can ever measure. I'm going to allow our guest speakers to just say some final words before handing over to Louise for a final message. Dr. Benn, would you care to start us off?
Caleb, you're fantastic. There's a missing place in medical school for you. Okay. Here we go. Well, thoroughly enjoyed. Thanks, everybody. Okay. Lisa, Dave.
Dr. Moodley?
To the people listening, remember, knowledge is power. So when you have all the information, you can hopefully make sensible decisions. Okay.
Yeah.
I often see patients who don't make sensible decisions.
Yeah.
That's okay. That's okay. We'll get there when we get there. The important thing is do the best you can with the information you have. We all do that every day in our lives.
Yeah. Very
Dr.
true
Jordan?
words.
Mine is just to say thank you to everybody. Thank you, Dr. Moodley, Prof Benn, Louise, and the Breast Health Foundation. This is an incredible platform that you started. I'm so excited to be a part of it. And to everybody watching, I just want to reiterate something Prof had spoken about briefly earlier about asking questions. I often come across patients who are scared to ask questions, and they've been scared to ask the doctor or somebody who saw them before those questions. I think as clinicians, we're excited when patients have questions because it means you're engaging, it means you're thinking, and we are on the same page. So questions, questions, questions. Thank you, everyone.
Absolutely.
Thank you so
Lou?
much. Louise, would you close for us?
Yes, thank you. Once again, thanks, Devin. Thanks, Carol. Thanks, Lisa. You have no idea what you've walked into at BHF. We'll keep you busy for a couple of years. Thank you. And once again, thank you for supporting us. It's always a pleasure having you guys chat with us in everyday language instead of doctor speak. And Caleb, thank you very much for joining us. I now know how to get hold of you. And can I just make one comment, young man? It's Professor, not Dr. Benn.
They only call me Prof when I don't listen, okay? Otherwise,
Sorry, I
okay.
only know her as mother.
They say Carol, but Caleb and Tia both say mother, okay? Then I know I'm in trouble. Okay, right, okay.
Thanks, everyone.
Thank you, everyone, for attending, and good night.
Bye-bye.
Everybody that joined us, thank you. We'll keep you up for the next
Thank you.
one. Bye.